Hi, good afternoon, or good morning, or good evening, wherever you are joining our webinar. Now we are again together in one of our ASPA Flex webinar series. This webinar is specially prepared by our ASPA Special Interest Group Sedation, Pediatric Sedation Group, and we will make a webinar, try to make a more vigorous webinar, different from the previous webinar styles, in a different format. We will delve into the pediatric sedation challenges, innovations, and best practices we have. We will have live debates, updates, and questions from you, and we try to answer them all. And we will be happy if you join as much as you can. I'm Serpil Özgen from Turkey, Istanbul, Turkey, and I'm a senior consultant in Acıbadem Health Group. I have a special interest in pediatric anesthesia and working with pediatric patients almost 25 years, and a special interest in pediatric sedation and dexmedetomidine. And in our webinar today, we will have the topics as the setting up a sedation service, which is amazing work, and we will try to define the depth of sedation in children and innovations in sedation and multimodal sedation in children. Over to you, Vivian.
Hi, everyone. Unfortunately, Dr. Billian Lee has emergency engagement, so she cannot join us. Actor, here to you.
Thank you. So I'm Dr. Ekta. I'm working currently in Department of Anesthesia, Christian Medical College, Vellore. I'm head there. I have few interests, but my special interest in sedation is because sedation is fascinating, is challenging, so it puts me in trouble or challenging zone most of the time. That's it for me. Over to Tracy.
Hi everyone, I'm Tracy. I'm a senior consultant in Pediatric Anesthesia Department in KK Women's and Children's Hospital in Singapore. I'm currently also chairing the Hospital Sedation Committee in KK. My special interests are that of procedural sedation, pediatric airway, and cardiac anesthesia. And today, I just wanted to thank ASPA for inviting me to be part of this discussion today so that we can all share our insights on procedural sedation and then we can all learn together. All right. Next one.
Hi everyone, I'm Yin Shi. I'm from Children's Hospital of Chongqing Medical University. I'm interested in pediatric anesthesia with cardiac neonatal anesthesia, ultrasound guided procedures, and sedations. It's very happy to join this webinar. Thank you.
Calvin. Calvin is our IT support. He's associate consultant of the Department of Anesthesiology and Perioperative Medicine. He has special interest in pediatric sedation, simulation training, and he's kind enough to help us as IT support today. And I'm Vivian Yuan from the Hong Kong Children's Hospital. I've been working in the Children's Hospital for like a number of years. You all know, I have special interest in pediatric sedation, that's with the Tomidine use in children and use of TCI. My interest in sedation started when I was working as an anesthesiology, even before I was doing anything about pediatric sedation. So about today's webinar, welcome you all. I hope you all will enjoy this webinar. But for today, the information presented in this webinar is intended for education purpose only and is not meant to be substitute for professional medical advice, diagnosis, or treatment. And the views expressed in this presentation are those of the presenter, and it do not necessarily reflect the opinions or policy of any institution or organization which they are affiliated with. Additionally, the information presented may not be applicable to all individuals or situations. You can use the Q&A box as frequent as you wish to send in your questions, comments, and your view about the topics we discuss. Chat and raise hand functions are disabled. Our moderator will highlight your question to the appropriate speaker. And for some simple question, we might answer by text in the Q&A box. And today we will have quite a number of polling. When the poll is launched, you have about 20 seconds to submit your answer. And after that, we will share the results with you. And with certificate of attendance, it will be automatically forwarded to you after you submit the post-webinar survey. The post-webinar survey will be sent to you tomorrow. That is the 21st of July. Sorry, I have not changed the date of this slide. And remember to submit your full name and email when you submit your survey. And like us on Facebook, visit our website and our YouTube channel, join ASPA by scanning the QR code. We are a nonprofit organization, so if you can also scan to donate to ASPA. Let's start our webinar today with a case. Sapio.
Yes. Now we have a case of 14 years old, 55 kg, 150 centimeters length. He has mental retardation and suffers from severe obstructive sleep apnea with nocturnal BPAP. He is using nocturnal BPAP. He has gyre malformation with extensive syringomyelia causing compression of cranial nerves. He has facial asymmetry and trismus with limited mouth opening. During operation for posterior fossa decompression, he has history of difficult intubation in previous anesthesia. Grade 3 larynx with video laryngoscopy was noted in his notes. Now you're requested to provide sedation for MRI brain after the operation 3 months postoperatively. So what would be the depth of sedation required for his MRI?
All right, at this point in time, I'd like to encourage all the audience and participants of this webinar to indicate your options, okay? Do you want to proceed with this MRI scan awake? Do you want to do it minimal, under minimal sedation, moderate sedation, deep sedation, or would you opt for general anesthesia? We will have about 20 to 30 seconds for the poll. Maybe just 10 more seconds and then we will end this poll. Okay, now we have the result. So it looks like we have a different threshold. Okay, 7% of us decided that we can try awake. 1/3 of us felt that we can try minimal sedation, and 1/5 of us think we can do moderate, and another 1/3 thinks we can do under general anesthesia. Since we are doing this webinar a little bit differently from the past, I would like to encourage the audience to actually share in the Q&A section the reasons why you have chosen the options. For instance, if you have chosen a general anesthesia, maybe you can share with the rest of the participants in the webinar and the panelists as well why you opted to do a GA, or why 1/3 of you have opted for minimal sedation. All right, next slide, please. All right, so before we embark on any sedation, let's just recap the levels of sedation. Okay, as shown on the screen, there are actually 3 levels of sedation: minimal sedation, moderate sedation, deep sedation before we enter general anesthesia. So for minimal sedation, previously it was known as anxiolysis, and then since the early 2000s, we have re-termed it as minimal sedation. And minimal sedation is essentially the state where a patient is able to respond to verbal command and still maintain his own airway and breathing. For moderate sedation, patient is in this state of depressed consciousness, but the patient is still able to maintain a purposeful response to verbal and tactile stimuli. As for deep sedation, the patient is usually not easily arousable and only responds to repeated or painful stimuli. And as for as for general anesthesia, usually there's of course loss of consciousness, and you won't be able to elicit any purposeful response to painful stimuli. So while the definitions are clearly spelled out, the sedation is truly just a continuum. Next slide, please. So as you can see, sedation is actually very, very dynamic when it comes to the depth. As we give a top-up dose of a sedative or increase the rate of infusion of any sedative, the patient may unintentionally be tipped into a deeper depth of sedation. As you can see on the screen, there's actually varying needs to support the patient's airway and hemodynamics. As we enter into a deeper plane of sedation, maybe even encroaching on general anesthesia, the risk of hypoventilation and apnea or even hemodynamic instability increases. So the physician at any point in time must be prepared to intervene and rescue the airway or hemodynamics as appropriate. Next slide, please. So the ultimate depth of sedation, I would say, will actually depends on these 3 P's and 3 D's. Okay, what are the P's? The P's are the patient himself or herself and associated medical conditions. Okay, and then the procedure itself, is a procedure purely diagnostic, or is it an interventional procedure which involves the element of pain, and then that may require a little bit more than just a single sedative. The physician's expertise and skill set will definitely be important. When it comes to the D's, the drug, is it a single sedative, or are we going to use multimodal agents, which will then have add-on effects? How about the dose itself? Is it going to be the initial bolus? You will see a faster and rapid onset compared to if you give it as a slow infusion for the loading dose. And the method of delivery matters as well, as I have illustrated earlier. Next slide, please. So with that in mind, I'd like to encourage our audience participation again by indicating in the Q&A your preferred regime when you choose to either sedate this patient, or if you want to do a GA, how would you go about doing it? So while we await for responses from the participants, I'd just like to invite one of the panelists, maybe Dr. Ekta, to share her thoughts on how she would go about providing either sedation or general anesthesia for this patient coming for MRI scan.
Thanks, Tracy, for the question. So this is a tough question. So as you can see, even I kind of juggle between very minimal sedation and, general anesthesia, given my situation, my country, my hospital, and my hands. Probably I would choose to give general anesthesia because of the fact that this patient is quite significantly posing challenges about respiratory system, the difficult airway, and OSA requiring BiPAP. Given the list which I deal on a day-to-day basis, where 15 cases are posted, I think, and only 2 persons posted there, I would like to ensure that the airway is in my hand and it's controlled probably. And I understand it's a painless procedure, but I would like to take this patient back to ICU after everything is done and extubate in a safe environment. That's me.
Thank you, Ekta, for sharing. I noticed in the chat that there's responses. One of the attendees said that they would start TCI dexmedetomidine together with TCI propofol. Can I encourage this attendee to also share with us what will your starting regimes be like? What will your loading dose for the dexmedetomidine be? Would you start the propofol first, or would you start the dexmedetomidine first? it'll be very interesting to find out. And then 2 other attendees have shared that they will just do GA because it says that the scan may be quite long, more than 30 minutes. And then I think Noor Afifa said that he says it's better to give GA because the patient has a history of difficult intubation and you want to secure the airway electively. So my question back to Noor is that in this scenario, how would you, where would you secure the airway in this case? Would you secure the airway in the MRI remote location induction room? Or would you choose to secure this airway in a setting where you're more familiar with in the operating theatre and then move the patient to the scan room? Maybe you can also type your answer and share with us. In the meantime, personally, by looking at this patient, I think I would probably may have to do a more thorough pre-operative assessment to check on the severity of the mental retardation for this patient and his cooperativity level, because AP is like amenable to maybe mass induction. I might like maybe do nitrous induction, set the IV plug, and then contemplate maybe doing a minimal to moderate sedation with low-dose propofol, because after all, this is just like a diagnostic scan. All right. Let's see. Do we have more responses from our attendees at this point in time? One say that they will try to do awake because child is 14 years old and maybe cooperative. But I think our patient in this case has mental retardation. So I'm not quite sure whether it's possible. I mean, we can always explore and then see whether it's we can proceed without anything. Let's see. Mo seems to have opted for dexmedetomidine sedation. Please share with us reasons for choosing dexmedetomidine infusion. Does the rest of the panelists have anything to chime in with regards to your experience as well, as we look at the audience responses? Oh, hi, Vivian, yes.
Yeah, I wonder it will be like a little difficult for achieving minimal or moderate sedation for this guy, because that means he might just move when you really don't want him to move, etc. So a lot of the time I just feel for young kids and for kids like this, they will either need deep sedation or general anesthesia. What do you think?
Yes, sorry, I was a little bit distracted because I was trying to reply to Noor's answer to my question to him earlier, because he said that he will secure the airway in the operating theatre and then move the patient to the MRI suite. Yes, I wanted to type and say to him that I totally agree, especially since this patient also has trismus, and sometimes the MRI anesthetic unit nurses may not be as trained as the operating theatre unit nurses when it comes to handling a potential difficult airway. All right, okay. Another participant has shared with us that she will consider doing midazolam 0.1 milligram per kg bolus and then start a dexmedetomidine infusion at 0.5 mics per kg per hour, and together also with propofol to sort of induce the sleep a little bit faster. And she also had concerns that the pain stimulus for MRI is because of the noisy scanner machines. Okay, so just wondering in this scenario, if the patient do obstruct in the scan room because we are using triple agents, so for what can we do then if that happens? So
Come
that
out.
So stop the scan, come out, and then rescue in the induction area.
I guess you can manipulate and see if you can have an open airway somehow with more extension, supporting, and so on. I have tried various means in the scan room to try and open up airway that's obstructed. And it's just one time I really need a nasal airway for a very obstructed airway. But if if the scenario is so bad that you have to support, then you just have to come back out, right?
Yes, I have tried before to insert a nasal pharyngeal airway in the scan room for a patient who happened to obstruct after I started on TCI propofol. All right, okay. We will continue to answer the questions while we move on with the webinar. But I'll thank everyone for participating in this segment. So we'll just end this short discussion for now. Vivian, next slide, please. All right. So just some take-home messages for this short segment on the depth of sedation. I just wanted to emphasize that sedation is actually really a continuum and it's very, very dynamic. There is no fixed sedation recipe, so we do really have to think of all the P's and the D's when we embark on any sedation. And sedation in a remote location, with or without a challenging airway, is definitely not child's play. Sometimes we do have to verify that sedation is actually warranted, and before we even agree to sedate the patient for the scan, and we definitely need to plan ahead. As illustrated earlier, we do have to intervene accordingly when needed. So some more food for thought for this segment, which we can actually discuss more in our ASPA forums, is will you admit this patient after the scan for further monitoring? Are you going to just accept this as a day case, sedate, and let the patient go home? Or the other question for you to think about is that if your sedation plan was unsuccessful and the patient requires a general anesthesia to complete the scan, what then will be your airway plan? Okay, with this, I shall end this segment now and then pass it on to Hector.
Thank you, Tracy, for that lovely discussion. So I will move on to 3 polls, but I would say that first 2 polls are more to understand what kind of services you have. And the third one, we can have a better discussion. So can we have the poll question? You have 30 seconds to answer this. What is the minimum eligibility criteria for providing sedation in your hospital? Choose one answer. Okay, we have 10 more seconds. All right, can we have the poll results? Interesting, very interesting. So I can see clearly most of you said pediatrician and anesthesiologist with BLS and PALS training. Then comes pediatrician and anesthesiologist. And then I can see any doctor who has understanding of physiology, this area, and the disease and airway management. Wonderful. So I would say we move on to second poll question. We can move on to second. Okay, now, who runs the sedation service in your hospital? We have another 30 seconds. Ten more seconds to go. All right, we have the results now. Okay, so interesting. Okay, so sedation services are run by anesthesiologists as per 50% of our delegates, and both anesthesiologists and pediatrician based on the hospital program. Okay, protocols. Okay, wonderful. We are going to discuss, you can write in the chat box more about if you want to share something about your sedation services and something you want to share about the hospital eligibility criterias. While we move on to the third poll question, if you have been given responsibility to create a sedation service by anesthesiologist for your setup, what are the major hurdles you think you're going to expect? We have 30 seconds for this poll also. Okay, we have 10 more seconds. Okay, we have the poll results. So I can see clearly 51% of you have said recruiting manpower for covering all sedations is a challenge, whereas some feel, 47% feel making protocols, and 45% feel procuring equipment's a financial burden. And then obviously few feel delay in diagnosis and treatment of patients occur if you have sedation services run only by anesthesiologist. All right. So at this point, let me look at the Q&A box and see if we have any questions there. So while we are having question, if I can ask our panelist to say while they were providing sedation services in their hospital, and if they have to provide by anesthesiologist, what do they think are going to be challenges in their setup? Can I open it to Dr. Serpil?
Hi. It's in our hospital and mostly in Turkey, the sedation services are run by anesthesiologists, very few with pediatricians or endoscopists, but usually anesthesiologists, especially the ASA 3 or more are consulted with anesthesiologists. In our hospital, we have a shortage of manpower as always, because usually we want to be in the operating theaters, not outside in the unknown environment. But I think day by day we are running it perfectly. But I believe it should be done by anesthesiologists.
Sure. Thanks, Dr. Serpil, for your
Thank you.
insight. Now I have not seen Q&A. I can start discussing with my slides while we'll hope that some questions will come. Can I have my slides? All right. Whenever we have to talk about sedation services or setting up a sedation services, there's no one answer. It depends on where you are, who you have, what is your setup. So basically 5 W's and 1 H you have to answer. But at the end of the day, you have to remember you need to be safe and you need to be effective, because in countries like ours where you have number of cases, a lot of cases posted on one day, you cannot be ineffective. Wasting time also is a problem. Can I have next slide? Can I have next slide? Yeah. So these are the components we must consider. There are many other components as well, but these are the basic things we must consider when we are setting up any sedation service. Understanding why are we doing MRI? So understanding the indications. A lot of time we also note that by default the physicians order MRI because that's just a follow-up MRI, but they don't understand the criticality of the situation. Like in this patient, what we just had, Dr. Tracy shared with us, we realized that it's a very challenging case. but it is a follow-up MRI. So we really need to sit down with primary physician and talk about the need of this MRI. Then, who is our patient? So answers may change, knowing our patient. If you're ASA grade 1 patient or 2 patient who is otherwise fit and well, coming for gastroscopy or MRI, you may not think twice, and you'll take the patient in, you'll provide the sedation for the procedure and just get on with it. But when the patient like this, what you just discussed, your answers may change. Who is the provider? Do your hospital have enough consultants to come to MRI and provide, or you have one consultant running 2 areas? So who is the provider? Who's going to be there at head end? That also decides how you're going to give sedation. And your site, no matter what happens, whatever situation you are, must have basic resuscitation equipments, must have defibrillator, must have the basic medications and the reasonable basic stuff which you need for running any sedation or GA for that matter. And the medications which you are comfortable with, you have to have full understanding of pharmacokinetics and dynamics. So these are basic things you remember you have to have while you plan for your sedation services. And also, if you have only 3 cases a day, if you have 15 cases a day, your plans may change. So basically, at the end of the day, how do you decide this? You please audit whatever you are doing at this point of time. And based on audit, what complications you see, what are the advantages of your setup, understand all that, and based on that, you create your own system. Next slide, please. Next slide, please. So when we talk about sedation, there are a number of places we sedate them. In OT and ICU is pretty much easy because the people around are very accomplished to handle airway, they are accomplished to monitor sick patients. But when you go to NORA situations and wards and OPDs and minor OTs, which are there in OPDs, you need to understand the system around there should have an availability of people either who know how to handle airway or something like emergency medical services should be available. Think about a situation where MRI is a standalone setup, and you have no emergency medical services there. You better don't do sedation processes there, and maybe you can do a non-sedation stuff there. Can I have the next slide? So with this, I will say the take-home message is very simple. You need to create a safe system with the close collaboration between hospital administrators and the end users. You need to do audit. It is a must. And you need to make sure your system needs careful, vigilant, aware, and patient-oriented doctors. Resources have to be basic minimum resources have to be available for your system, and policies should be, or I would actually go on the other side and say must be created based on your situations. With this, I end my session, and I don't see many questions coming up regarding this. So let me just say, okay, sometimes sedation give attempt of sedation to MRI successful. I mean, I don't see.
Ekta, only one question that sometimes in their hospitals, pediatricians or endoscopists begin the sedation and call for anesthesiologist. Is there a protocol to use when to call, or after which step you can call the anesthesiologist?
Ideally, yes, there should be a protocol, but I think if your system is not very developed, and then you probably at the beginning itself, you decide whether you want pediatrician to go ahead and give sedation to this child, or from the beginning you give it off to anesthetist if the patient is challenging. I think for developing countries like ours, triaging is very important, I would say. Triage early. Okay, with this,
Thank you.
Yeah, thank you. Thank you. Yeah. Next slide. Okay, yeah. So I would love to invite Dr. Shu Ying and talk about innovation in sedation. Over to you, Dr. Shu Ying.
Yes, thank you. Good afternoon, distinguished guests and colleagues. I'm Professor Xu Ying from the Department of Anesthesiologist, Children's Hospital of Chongqing Medical University. It's my honor to present our innovative work in pediatric sedation today. Next slide. You know, our hospital is the largest pediatric medical center in southwest of China. We serve millions of patients and nurses and across 2 major campuses. With thousands of inpatient beds and leading specialists, we provide complete care while advancing pediatric research. Next, please. As a regional leader in pediatric anesthesia and sedation, our department operated across 2 advanced facilities, features 36 specialized operating rooms, dedicated sedation centers, and an expert team of anesthesiologists and nurses. We safely perform 120,000 procedures, from surgeries to procedure sedations, about 70,000 pediatric sedations. Next, please. Crucially, we deliver over 70,000 sedation per year. This massive value is managed by just 6 anesthesiologists and 24 anesthesia nurses. This imbalance creates significant safety and efficiency pressures. To solve this, we developed 3 core innovations. First, modal innovation, gear driving workflow, and 2 is digital innovation, SIRS and MPST, and intelligence innovation, AI-powered, and using AI tools. We have finished half of million cases, and by far, and 0 major adverse events. Next, please. Our workflow has 2 parts. For no-risk staff like TTE, EEG, and hearing test, we use a 1-to-N setup. 1 sedation team, a doctor with 3 or 4 nurses handles multiple patients at once. Next, please. For higher risk staff, especially MRA, we switched to 1-to-1, 1 anesthesiologist per patient. 3 core innovation optimize the resources, utilization without compromising safety. Next, please. Model innovation, we have 106 process gear driving workflow. Those synchronize like precision gears, driving seamless transition between processes to deliver reliable, consistent patient care at every step. Let's watch a video to see the operational workflow in action. Please.
Our system works like perfectly meshed gears. 5 specialized roles working in sync through 6 smart processes to deliver safe sedation efficiently. Gear 1. Guidance. The patient arrives at the sedation center accompanied by parents. The guide nurse completes synchronization of the patient's basic information from his to the sedation information system SIS, and collects additional on-site data e.g. weight, temperature, examination. After registration, the child awaits anesthesiologist's call in the queue. Gear 2. Consultation. During the consultation, the anesthesiologist conducts patient assessment and completes documentation, including evaluation forms, informed consent, and medical orders. When prescribing, the sedation information system assists with dose calculations and medication recommendations tailored to the child's profile. Historical adverse medication events trigger automated alerts. Gear 3. Coordination. Our general nurse coordinates medication, timing according to the anesthesiologist's orders, and examination department schedules. Gear 4. Medication. When calling the child for medication, the sedation nurse applies wireless vital sign monitors and attaches a car-coded identity label. After verifying identity, sedation medication is administered. Gear 5. Examination. Throughout the examination, wireless devices continuously monitor vital signs. The system automatically detects anomalies, stratifies risk levels, and triggers alarms to notify staff during high-risk events. Gear 6. Recovery. After the procedure, the child returns to the sedation center for recovery. Once fully awake and stable, the nurse completes the recovery assessment, and the system automatically generates a sedation report.
Please next. Okay. You can see we have a digital synchronization. Please, okay, yes. We have three digital synchronization. You can his hospital information system. He can provide a historical record, patient insight, and this sedation information system. Information system offer precision sedation management data, and IoT is the Internet of Things. And use the wearable device generate continuous vital signs and for active monitoring. Next. We have intelligence innovation AI-powered early warning and AI assistant decision support. This can give us more information to help us to make a decision. Next. Please, okay. These solutions are now being commercialized, expanding to more than 20 hospitals across China to deliver safer, more efficient pediatric sedation. By innovating in operational models, digital integration, and AI safety, we will achieve the large-scale implementation without compromising safety. Please, next. Through model, digital, and intelligent innovation, we have built a safe, efficient, and standardized system. We shall continue to move forward along this path. Thank you for your attention. Okay.
Thank you, Shi. It's very impressive
Thank you.
model of sedation. Any comment from the panelists?
Dr. Vivian, I mean, as I am mesmerized, I can see the audience also is mesmerized. They are just absorbing it. I think, thank you, Dr. Shuing, for sharing your insight and your model. Thank you.
Yes, thank you. Okay, thank you, attention.
Yeah, Tracy.
Yeah, thanks, Shing, for sharing the wonderful technology that your hospital is using and that you're pushing out nationwide to the rest of the hospitals in China. Can I just check, how do you educate your nurses? And because you're doing like 70,000 sedations in your year, a year, what's your teaching protocol, and how do you also do the audit for the sedations that you have performed?
Okay, in our nurse will train in operating room, and they always stayed in PACU for recovery patient. When they have a experience to do with PACU patient, they can do in sedation center. Yes.
Okay. Is our sedation center the same level as the operating theater, or is a different building?
In same building, but it's built at the examining like EEG and hearing records around this examination suite.
Okay, so certain procedures are located elsewhere in the clinics.
Yes.
Okay,
Yes.
all right. Yeah, thank you for sharing. I think there's a question in the chat for you, Dr. Sheen, which is asking what kind of vitals does the remote monitoring pick up? Because we saw in the video that the parent is given a lanyard with a monitor, and so they will transmit the vitals to your central station. So does that monitoring include transcutaneous carbon dioxide monitoring?
No carbon dioxide monitor, just SpO2 and heart heat rate.
Rate, I see. Okay, and how is that picked up? Is that picked up through a sensor around the patient's? Was it a wrist tag that I saw in the video? Was it picked up through that and it get wisely transmitted to the control station? The control
Yes.
monitor.
This information will transform to sedation center. Yes.
One more question is that, is it standard medication will be to all patients?
Yes,
who administer them?
In ASA 1 or 2 patient, we always use oral or nasal medication. About 90%, 90%, 90%.
So there is a
Is
question.
it standard? Okay.
Yes,
Okay,
it's
Vivian.
standard. Yes, we use the our software. You search, since you know the sedation system. You know, we have a sedation system, sedation information system. This system can help us to calculate medication dose automatically.
So may I ask, how do you decide whether to give oral carbohydrate or nasal dexmedetomidine? Or it depends on the procedure or the age of the patient?
Yes, we always use the because it's needed to deep sedation. We always use the oral and nasal medication. You know,
Together.
yes, it's 1 to N model. We always use nasal and oral medication. if we use introverts, always use the MRI scan. We always use in introverts.
Intravenous for MRI, yes.
Yes, intravenous for MRI.
For MRI, one anesthesiologist, one patient intravenous. For other, it's
Yes.
always oral and nasal medication for the procedure that is 1 to N. So you have, I understand you have 2 sedation centers. So in each center, all the sedation happens in the center, and then the examination happens close by the center.
Close.
Like next to the center or in the center? Okay.
Yes, closely. We are sedation center is the central, and other exam suit around our center. You know.
Right. So there is a question. The participant asked, what happened if there is an airway issue for the patient who receives sedation in the 1 to N model in your sedation center? Or do you ever encounter airway problem like hypoventilation, breathing issue, needing more support?
Yes, you know, if the patient is ASI 3 or 4, we need to emphasize the patient more. We will deal with the airway problem, and always accompany with patient to the examination suite.
Right.
Okay.
And Dr. Sheen, just to add on, so how fast can the anesthesiologist get to the patient who develops adverse reaction to your sedation, whether it's desaturation, bradycardia? Can it get to the patient within 1 minute of alarms?
You know, we need to make sure the patient is okay, like the breathing is everything is okay. I just make the patient to leave our sedation center, you know. Yeah.
Okay, all right. But if the patient, let's say, desaturated, that means like the saturation is like 92%. So what will happen?
Like what?
If the oxygenation is not great.
就是氧气不好的时候，谁会去处理这个病人？
对，如果氧气不好。
Okay, you know, we will 我们会教育那个我们的检查科室的医生，让他们先在那里处理，然后我们会随着去处理。
在1分钟内吗？几分钟内？
很快 quickly.
Quickly, okay.
Can we have the answer in English as well?
Okay, I'm sorry.
So I think we were asking how quick the response will be in case of adverse events like desaturation, hypoxemia. Usually there is a medical doctor in the center and they will respond promptly.
Yeah.
So maybe in the future we hope to see you sharing the data like the adverse events, incidents, and severity. That will be very interesting in such a massive scale of service. Very good. Thank you, Sui Ying. And then we will come to our last part, and we will come back to our patient. So our patient now, remember, he's a 14-year-old with mental retardation, with difficult airway, has a history of Chiari malformation, had brainstem decompression. Now it's about 6 months after decompression. And he unfortunately went very sick, admitted to ICU for sepsis and toxic shock syndrome 2 weeks ago. He went a long way, went from mechanical ventilation and inotropic support. However, now he has an elbow abscess, and because of that, he became delirium. He needed urgent incision and drainage for his abscess. And as a result, the ICU has to restrain him because he was quite delirious, and he was just commenced on low dose desmethyltomidine infusion for his delirium, put on high flow nasal oxygen with FiO2 at 25%, and you are asked to provide anesthesia for this patient for the IND. So we know the patient with his history of difficult airway, and now and also he has a history of OSA, and he also had a prolonged stay in ICU because of his sepsis. Would you prefer to do general anesthesia and regional, or maybe sedation? Okay, I think we can end the poll here. Thank you. I think I can see about 30% of the participants will prefer general anesthesia, 30% will prefer general anesthesia and regional anesthesia, and then some actually will prefer sedation and regional anesthesia. Actually, it was a very difficult case for me also, so I was really struggling what I should do, because I know he has difficult airway. I know he has OSA, so he would most likely be obstructed when we sedate him. So what can I do? But I really don't want to put him back on ventilator. So in the end, I decided that we should try regional anesthesia with sedation first. So say if this is also your plan, do you agree that we should limit the number of medication to avoid adverse events in anesthesiologist-led sedation? So this is a very simple question, just yes or no. But you can also say you are not sure. Okay, thank you. I think we can end here. About 3/4 of the participants would think we should limit the number of medication used, and only 1/4 of the participants thinks we can use multimodal technique. So as we all know, in this paper, it's quite an old paper that was presented, I think, like 2 or 3 decades ago. In this paper, it revealed that medication-related adverse events in pediatric sedation is not actually related to what drug you use or the route of administration. It's more related to the combination of drug and drug interaction, and of course drug overdose, and who administered the medication. So it implied that if you use more drugs, like more combination, you have higher risk of running into adverse events. However, recently, we also have read paper like this, the synergistic effects of desmethyltomidine and propofol for patients undergoing deep sedation. It has demonstrated that adding one drug to another, actually we exploit the synergistic effect, and not only that we need less of each drug, but we also has less incidence of adverse events like airway issues or hemodynamic issue by combining desmethyltomidine to propofol. So there is actually some advantage of combining different drugs together to achieve the deep sedation state in pediatric population. So maybe I just present to you after we struggle whether we should sedate or we should do general anesthesia, we decided we should try sedation first and see if we can do sedation with regional anesthesia so that he would not be put on the ventilator again. And very fortunate, when the patient arrived operating theater, he was calm with dexmedetomidine just 0.2 mic per kilo per hour. So I increased the dexmedetomidine to 0.5 mic per kilo per hour. With small boluses of ketamine, we were able to examine his brachial plexus, decided the approach for brachial plexus, and there I started low dose of TCI propofol. And with just 0.5 mic per mil, I needed to support his airway with chin lift. And then for the rest of the procedure, I was only running dexmedetomidine as well as propofol at the CE level of 0.3 mic per mil for the brachial plexus to complete and for the procedure to complete. And he was able to maintain sponge ventilation with high flow nasal cannula and lowish FiO2 for the whole procedure. So this illustrates that with titration, of course, by an anesthesiologist, we can actually achieve a state of sedation that allow procedure to complete. Of course, this is under the effect of regional anesthesia when we take away the pain of the procedure. And I have mentioned TCI technology in sedation. Of course, with TCI that has been used increasingly commonly, there is a theoretical advantage of giving propofol via target control infusion because it is titrate. We can very intuitively and easily titrate the level of sedation using this using the TCI machine. And it might be especially beneficial in patients who are high risk on sedation. For example, with patients with extreme weight, medically complex, and undergoing complex procedure. And as an anesthesiology, we can explore using this technique to ensure and also promote safe sedation in the pediatric population. And recently, we have also seen the use the model for dexmedetomidine that has been available. I will be delighted to see any participant who has used TCI dexmedetomidine in pediatric population, because just now I think there was a participant who mentioned that he would use TCI dexmedetomidine as well as propofol for MRI sedation for this kid. I think in the end, we have mentioned role of anesthesiologists in sedation. Overall, we should ensure safe sedation practice across an institute. We have a responsibility in training and credentialing. And also a lot of the time we add as emergency backup for complication or for difficult cases. And increasingly, I think we have more complex patient, difficult patient. So anesthesiologist has an important role of direct involvement in high-risk sedation for complex prolonged procedure like MRI, cardiac MRI, intervention, or more invasive procedure, and also for high-risk patient with medical problem or prolonged painful procedure. And because of the medical legal risk, Institute may also increasingly mandate anesthesia team for deep sedation to mitigate liability. As an anesthesiologist, we can also introduce advanced innovation like what Ying-Shui has introduced, and also advanced technique like the use of multimodal sedation technique or target control infusion in sedation. So with that, we would like to see if we have any question from the participant.
Hi, Dr.
Yeah,
Please go
yeah,
ahead.
Ekta, please go ahead.
So a couple of questions, I think, for you, Dr. Vivian. The regional anesthesia may not work because of infection is one of the thing.
Oh, yeah, because for this kid, he has elbow abscess and we do a brachial plexus, so it works for him.
Okay. And then Dr. Agnes asked, won't IV ketamine be good enough for IND?
I think I'm not sure. I have not used IV ketamine solely for painful procedure. A lot of the time, I will mix in some other things. Like I will try to use a baseline, like a background of dexmedetomidine if I use ketamine for painful procedure. But if you just use ketamine for very painful procedure like an IND, I think you need like very high dose general anesthesia dose. I have not done that.
Yeah.
I don't know for other handlers. Yeah.
I think when I was doing my education in government setup, I have used IV ketamine because other drugs were not available. But as you said, doses required will be high.
What about delirium and ketamine? What about delirium and ketamine?
Oh, yeah, definitely an issue. So that's why I like to supplement other drug, and I use ketamine mostly just for pain, not for anesthesia. So I try and use other things for sedation or anesthesia while the ketamine is used for pain as like a sub-anesthetic dose. And also nausea and vomiting is an issue with high dose ketamine.
Yes, yes. Sometimes we don't have any options, then IV ketamine is a good option in those conditions. Yeah. There's one more question, Dr. Vivian. What is your experience on use of dexmedetomidine alone for MRI sedation? Maybe all of us actually, but I'll give it to you. Doses.
I think many people has the same experience. Dex alone at our usual sedation dose is not enough, so you have to do something, add some other stuff. Long ago when Kira Mason has tried and used dexmedetomidine as the sole agent for MRI and CT scan, it's about 2 to 3 times the dose we use currently. So it still works, but as a single agent, it still works. And I think it has the advantage because then you don't have to titrate or maybe like less demand for the practitioner because it was a nurse administered sedation. But I guess if you have the ability to titrate as an anesthesiologist, I would rather titrate in some other drugs so that it's adequate for the sedation and the procedure.
Thanks, Dr. Vivian. One more question. Won't dexmedetomidine tackle the delirium of ketamine? Yeah, I guess it will, right?
Yeah, I guess so, but I guess it's a research topic. I don't think like people have studied midazolam and ketamine, but not quite for dex and ketamine combo. But it has been well known that dex and ketamine combo are good complementary drugs to each other for sedation and painful procedure.
There's one for children in cath lab. Do you use sedation with local anesthesia or general anesthesia, for example, PDA closure? I guess again it's an open question. It's a common open.
Maybe Tracy can share your experience.
I think if they're going for PDA device closure, I think it depends on your center. For instance, in KK, our cardiologists usually like to do even TTE and TE prior to the device closure because they do need to measure the size of the PDA, and so it ends up to be like kind of a fairly long procedure. So most of the time we actually do general anesthesia instead of just doing a pure sedation in this case. Yeah. So I mean that's for the experience in my center. Yeah, but I believe that in more advanced centers, there might be people who might be doing sedation, or maybe I would say deep sedation.
Anyone else?
Yes, I think for us also, Dr. Vivian, probably GA, because it's procedural, movements are not appreciated at that point of time. And as Dr. Tracy said, sometimes it can be challenging and duration can be a problem. So for us also the same.
Yeah, I guess when I did this in like I did cardiac cath in country like Tibet where we do sedation. However, at our hospital in Hong Kong, we do general anesthesia.
Yes.
Vivian, for your case, what do you think of the triple combinations of TCI propofol, TCI dexmedetomidine together with IV ketamine instead of doing brachial plexus block? Because the child has mental retardation, right? I mean, will the child get really distressed after the surgery with a limb that's immobile?
Oh, I think I would still want to do a regional block for pain relief. And in my memory, when he was not delirious, like after his pain and sepsis was controlled, I could actually like communicate a bit to him. He can, voice out his discomfort or his discontent, etc. So I think it's hard for, if it's a big wound, maybe it's good if we can have regional in place. If it's a small wound, then I mean, just simple analgesia will do.
There's another question in the chat. A participant just asked, what is the ideal sedation of choice in a pediatric patient with OSA and stable C-spine for fiber optic intubation? Would anyone like to chime in on this?
This is for next year's webinar. Unstable. I guess it also depends on how old the kid is, right?
So the question is sedation for fiber optic in unstable spine, is that?
Yes, I think
And
so.
also,
Yeah, I'm not sure whether it's elective intubation in preparation for a procedure or just a post-traumatic unstable C-spine for intubation to be admitted to ICU.
Okay.
I guess fiber optic is somehow difficult in children because they have faster respiratory rate, smaller airway. You have to have the good FOB. Also, sometimes when the fiber is too small, you have no suction, right?
Yes, usually you need a size 2.8 bronchoscope with suction capacity. And I think it is just mentioned by the same participant that the child is a teenager and the intubation is for cervical spine fixation. So sounds like it's for pre-surgical intubation. I think I think this involves more than just sedation. You need good airway topicalization as well to facilitate a successful bronchoscopic aided intubation. And of course, I think to facilitate the sedation, you'll probably be best guided by, I think, pre-op counseling, as well as I think the use of processed EEG monitors to guide the depth of sedation, and then together the topicalization and an experienced procedurist in this case. I don't think it's something for a novice to do in this case.
Probably, I don't know. I'm just correct me if I'm wrong. I'm just thinking, teenager. I think inhalational induction, sevoflurane, and give CPAP as you're doing. It's unstable C-spine, so I stabilize it. And with that, if nasopharyngeal airway, I will put off that nasopharyngeal airway and continue giving, my inhalational induction with the Mapleson circuit, one of the open circuits, and then do intubation through the other nose, probably. Because depth of anesthesia, you can add dexmedetomidine to it to make sure the depth of anesthesia is maintained throughout, because it's inhalational on one side. Probably that's how I will think.
Sabir?
And I think the titration of the drugs is the one of the most important points. Either sevoflurane or you use propofol, slowly giving without suppressing the spontaneous respiration. Remifentanil may help, but not with overdoses or boluses, just to blunt the airway reflexes. And I think with fiber optic, sometimes video laryngoscopic fiber optic will also help. Two anesthetists, one with video laryngoscope and the other with fiber optic, so it may be more safer.
Probably it's unstable spine, no, Dr. Serpil?
Yeah. Not
Okay.
without extension.
Yeah, stabilizing that throughout, I think.
Yes.
But I think my approach will be IV induction in self-gas. If you have experience using TCI to induce kids, comparing to sevoflurane, you can actually appreciate it's much easier to handle airway because they don't have the tightness when you are, going into deeper sedation. Like before you are deep enough, there's always like a time when you have to give more support. They are almost like running into a laryngeal spasm. But with TCI, actually, you can slowly take over the ventilation and taking over the airway of the patient as they go deeper, even before they require chin lift or jaw thrust. So I guess IV is also another approach to difficult airway. And with TCI, it really helps a lot because then you can slowly titrate in the drug to what the patient needs.
Thanks for your insight, Dr. Vivian. I think I have we need to do a little more hands-on on TCI. We'll reach that.
Okay, I think it goes very well. Thank you for the participant. We see a lot of enthusiastic questions. So hopefully, if we have more opportunity, we can run webinar like this again. And you might have even more questions on sedation in children, like how to sedate a younger kids or neonate, how to run a sedation service, or how to advocate safety for sedation in your institute, and what will be the role of anesthesiologists. We can talk about this or even have some collaboration on sedation by joining or signing up on the sedation SIG. We will shortly post the SIG sign up on the ASPA website. And on the ASPA forum, hopefully we can do more case sharing, update, collaboration, networking, etc. So to fill in the post-webinar survey, it will be sent to you tomorrow. Remember your full name and your email, then you will have your certificate of attendance. If you have not joined ASPA, please join us by scanning this QR code, visiting our website, follow our YouTube channel and or our website. And our next webinar will be run by the Pain SIG, Faces of Pain. It will happen on the 21st of September. And come and join us in 2026. Our ASPA annual meeting will be in India, in Vinlore. It will be hosted by actor. So do come in 2026, save the date. And
All
I
welcome.
think that's all for us for today. Thank you very much.
Thank
So
you
we
for
see you
joining
all
us.
again. Yeah. Thank you.
Thank you.
Continue asking your questions at the forum.